Hello and welcome to another Intensive Care at Home and intensivecare.hotline.com emergency Q&A for families in intensive care and intensive care at home. Thank you so much for joining the live stream or watching this on replay. I really appreciate your support. So today I will answer questions for families in intensive care or families with intensive care at home. Before I go into today's questions, what makes me qualified to answer questions for families in intensive care or intensive care at home? My name again is Patrick Hutzel. I'm a critical care nurse by background. I have worked in critical care for nearly 25 years in 3 different countries, where I also worked as a nurse manager for over 5 years. And I've been consulting and advocating for families in intensive care since 2013 at intensivecare.hotline.com. And you can verify the work that we've done with Intensive Care Hotline at intensivecare.hotline.com. Have a look at our testimonial section or have a look at our podcast section where we've done client interviews. I am also the founder and managing director of Intensive Care at Home. With Intensive Care at Home, you can find more information at intensivecare@home.com. With Intensive Care at Home, we're sending critical care nurses with a minimum of 2 years critical care nursing experience into people's home, predominantly for long-term ventilated adults and children with tracheostomies, but also for otherwise medically complex patients, adults and children that have PICC line, central lines, port, catheters, Hickman's lines, and so forth, for home TPN, home IV potassium, home IV magnesium infusions. We're doing home tracheostomy care for adults and children that are not ventilated. We are doing BiPAP, CPAP ventilation at home for clients that don't have a tracheostomy. We're also providing seizure management at home with Intensive Care at Home. We are currently operating all around Australia in all major capital cities, as well as in all regional and rural areas. We are NDIS approved, an NDIS approved provider. We're also providing level 2 and level 3 NDIS support, coordination and case management. We're also TAC and WorkSafe approved in Victoria, iCare in New South Wales, NIISQ in Queensland, as well as DVA all around Australia. Now, without further ado, let's get started with some questions. If you have questions while you're watching this live on the show, please type your questions into the chat pad or join me live here with the StreamYard link that I've just posted in the chat pad. So please join the StreamYard link and you can talk to me live directly here, and I will answer all your questions live on the show here. If there are no questions for now, I will read out questions that I have received during the week. So first question that has come in is from Michelle, who says, "Hi Patrick, my dad was admitted to ICU this past Friday due to a pulmonary embolism which caused a cardiac arrest. He received CPR upon emergency department arrival, but they would lose his pulse and reinitiate CPR. CPR stands for cardiopulmonary resuscitation. It basically means, doing cardiac compressions, manual cardiac compressions. This occurred for up to an hour in the emergency department before they were able to get a stable pulse again. And my dad was breathing on his own with limited help from the ventilator. So also when someone is having CPR for up to an hour, they would have been intubated by then. That means they would have been put on a ventilator. While in the emergency department, we were told that he was responding to pain and lifted one arm and he could hear us. He was sedated and treated with hypothermia and moved to a bed in ICU. Day 2 on Saturday evening, sedation was removed and he was breathing with limited support from the ventilator. Arm movement was observed, eyes would open and blink, but no tracking and no response to commands or pain. We are told that he may have a brain injury, a anoxic brain injury, due to the time needed for CPR. Sunday and Monday, he's still non-responsive, no gag reflex, no pupil dilation, blood pressure dropped a bit, and additional medications were introduced. We were told a CT scan will not be performed due to him not responding to pain, absence of gag reflex, etc., and that the CT scan and EEG would not be helpful due to his non-responsiveness. We have felt pressured to agree to a DNR if his heart stops and to prepare for end of life. I would like to know if we should request a CT scan and EEG and get the results before making any future decisions. Should we allow my dad more time for recovery? I am at a loss right now. Please let me know what you think, from Michelle. Thank you, Michelle, for writing such a detailed description of what's happened to your dad. Now, let's get to your first question. Should you allow your dad more time for recovery? Absolutely, yes. It's only been 3 days, not a long time. And why would they not do a CT scan of the brain or an EEG? I've never seen that, especially if there is potential for an anoxic or a hypoxic brain injury, right? That needs to be verified. The reason it needs to be verified is, A, you want to know what you're dealing with, and you don't want to have any ifs and buts, and you need clarity. But I'm also wondering why they can't offer your dad an MRI scan of the brain, which would be even more detailed. But here is another thing. So from my extensive experience, patients are in an induced coma, and they may not have a brain injury, and they're not waking up when you wean them off sedation and the induced coma. They may just simply take their time because they are critically ill. And for anyone having a critical illness, they might take their time waking up. And whilst there is definitely a chance that your dad might have sustained an anoxic or a hypoxic brain injury throughout 1 hour of CPR on and off, right? There is a risk for that. That needs to be verified and can't be left to speculation, right? Because at the moment, what they're doing is they are speculating, right? Whilst, again, with him having no gag reflex, no pupil dilation, there is definitely a high risk that your dad sustained a brain injury. But once again, you can't leave that up to speculation, and that needs to be verified in a CT scan or an MRI scan of the brain, as well as an EEG. Well, here's another thing that you haven't mentioned. Some patients after cardiac arrest or prolonged cardiac arrest and prolonged CPR with brain damage, they might end up with seizures, right? Or they might end up with myoclonic jerks, which might look like seizures, but are sort of ongoing. I've seen this many times where, patients might have myoclonic jerks and seizures simultaneously. You haven't mentioned any of that. And is that because he's on too much sedation? Is that because he's on anti-seizure medications? Once again, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. So, you are missing some critical pieces here. Also, you are saying his blood pressure dropped. So has a cardiologist seen him? Was there any time to get him to the catheter lab and screen his coronary arteries, do an angiogram? I doubt that there has been time for it because your dad was probably too unstable. But, you may also want to find out what led to the cardiac arrest, and that can often only be found out by, once again, ultrasound of the heart, CT scan of the heart, ideally an angiogram of the heart, So you got to speak to a cardiologist. If his blood pressure dropped, why is that? Is that because of sedatives? Is that because he's potentially getting an infection developing into a sepsis? Is that because his ejection fraction is poor after the cardiac arrest, i.e. the contractility of the heart, right? If his blood pressure dropped, is he on inotropes or vasopressors such as noradrenaline, norepinephrine, epinephrine, adrenaline, milrinone, dobutamine, dopamine, phenylephrine, vasopressin, and the list goes on, right? Have you asked all those questions? Do you, more importantly, have access to the medical records so you can share them with us and we can help you interpret what's being given, what's being said, also what's been documented in the medical records, right? That would be critically important to find out what has happened there. The devil is in the detail. But once again, I have not really seen that someone has not had a CT scan after a suspected hypoxic or anoxic brain injury. Now, also, you are saying in your email that you have felt pressure to agree to a DNR if his heart stops and to prepare for end of life. Okay, well, you felt pressure to agree to a DNR. Okay, well, my response to that is always, you can choose how you feel. Think about that. You are letting them push your buttons. Nobody, and I mean nobody, can force you to sign a DNR. Right? So, you can choose how you feel, and you actually need to take responsibility how you feel. Because if they can push your button or your buttons, you are giving in to the perceived authority. No need for that. The law is on your side. Nobody can force you to sign a DNR. Okay? And in terms of you making future decisions, right? Yes, you should wait for the CT scan. Yes, you should wait for the EEG. And yes, you should wait for an MRI scan. You should give this as much time as possible. The question that you need to ask yourself is, what is the rush and the urgency to kill your dad? What's the rush? What's the urgency? Right? Plenty of time to talk about end of life. Plenty of time. You can withdraw treatment in a week's time when you have more clarity, but you need someone to look over the medical records or talk to the doctors and nurses directly, right? And should you allow to give your dad more time for recovery? Absolutely. Recovery only happens over time, as a matter of fact. One thing is for sure, if you withdraw treatment today, you know the outcome. Your dad's going to die. If you don't withdraw treatment today and you will give it time, you don't know the outcome, but you will give him a fighting chance, right? Also, you should be making decisions today that you don't regret in 12 months' time. So what I mean by that is, so let's just say, you'd be agreeing to stop treatment tomorrow and your dad passes away. Would you regret that in 12 months' time? Project yourself out. Would you regret that even in 2 weeks' time? Right? Think about that. Think about that logically. At the moment, you're probably running on adrenaline, you're running on emotion, which is understandable, right? But you got to let this sink in. Also, 3-4 days in ICU is not a long time. Way too early to make any hasty decisions. Now, also, what is the intensive care team's worst case scenario? Their worst case scenario is to look after someone indefinitely with an uncertain outcome. And I believe your dad is in that situation. And that's the intensive care team's perception, that your dad is in an uncertain situation, in a situation with an uncertain outcome, and they may look after him indefinitely. If he can't come off the ventilator, he may need a tracheostomy, which could prolong his life, And that would be an undesirable situation for many intensive care units, right? So you absolutely have to give this time, and you have to project yourself 12 months out from today and make the decision today that you don't regret in 12 months' time. Also, I have been talking about this for a long time, right? But I bring it up here again because I think it is timely to talk about it. I've been talking about real versus perceived end-of-life situations in intensive care for a long time. So what's a real end-of-life situation? A real end-of-life situation is, a situation where a patient in ICU is going to die, regardless of what treatment, medication, surgery, equipment you throw, any other resource you might throw at this situation. And the patient's going to die one way or another. That is a real end-of-life situation. I believe your dad is in a perceived end-of-life situation where the intensive care team wants to stop treatment without having it a full go, and it's their perception that he might die, and he will die if they're going to stop treatment now. But if he's going to improve, right, it'll make it more difficult for them to let him go, because every day your dad is going to live, their argument of him dying is going out of the window, right? And just because he's got no gag reflex at the moment, no pupil dilation, wait, give it time, He may simply also be over sedated, right? He may simply still be over sedated. You got to give this time, and you got to think about it carefully. You also have to think about, what would your dad decide if he could make decisions for himself, and base your decisions on that. Okay. So I hope that helps and answers your question. Now, if you have any questions, type them into the chat pad, or type them into the chat pad, or join me live on the StreamYard link here, and you can talk to me directly. If there are no other questions for now, I will move on to the next question. And that question comes from Nate. Nate says, "Hi, Patrick. The hospital is trying to shove my father into a room to die and forcing comfort care onto him, and not even wanting to continue antibiotics or even fluids. Cornering us as a family and trying to force their decisions on us. This hospital is not a very big hospital, but I need some advice on what to change immediately, because I just visited my father last week and everything was fine. And the long-term facility he was in was a very, very abusive and harassed him. And he continued to fall out of bed because he can't move his legs, because he was getting sick. And they were yelling at him to get up and threaten him that they're going to take him to the hospital, etc. And then after that, it's like he's in a coma state. He's in ICU now, but it looks like he might be getting there. He has all these issues, all these small issues that we shouldn't even try to do anything, but he doesn't have a heart monitor next to, he's an ICU patient now, but he gets there. He has all these issues, all these small issues that we shouldn't even try to do anything. We've all made it very clear that he is a full code and he doesn't have any type of DNR or NFR, and he wants us to try as hard as we can. The only thing we've all made it very clear that he is a full code and he doesn't have any type of DNR or NFR, and he wants us to try as hard as we can. The only thing he doesn't want is ventilation, but yet he doesn't have a heart monitor next to him. He's not on fluids. He's got oxygen in his nose. That's it. That's him. He doesn't have any fluids. He got oxygen in his nose. And he's listed and has full code if anything does happen. How does this make sense? Well, thank you so much, Nate, for sharing this difficult situation for your dad. Well, once again, similar to Michelle before, no one can force you or your dad to agree to NFR or DNR. No one. Let me make this abundantly clear that nobody can force you to agree to NFR or DNR. That's your decision or your dad's decision if your dad is in a situation where he can make his own decision. Now, you're saying on the one hand, he wants everything to be done. On the other hand, you're saying that he doesn't want to be ventilated. Now, and it looks like he's holding his own with oxygen in his nose at the moment. Doesn't look like he needs a ventilator right now. However, if he wants everything to be done, that includes mechanical ventilation, right? So you have to think about whether you want that or you don't want that for your dad, or whether your dad wants it or doesn't want it, you know? Because let's just give a hypothetical example here, and this also ties in with our previous email from Michelle. If someone needs CPR, cardiopulmonary resuscitation, if someone needs cardiac compressions, they most of the time also need mechanical ventilation during CPR. So for you to say you want your dad resuscitated, but you don't want him to have a ventilator, that doesn't really work. It's a bit like saying, yeah, I want to go on a holiday with the airplane, but I don't want to fly, but put me in the airplane anyway, right? So you can't have both worlds here, right? Chances are very, very, very high that if your dad needs CPR, that he needs a ventilator, right? And you would need to document that in his advanced care plan, or you would need to talk to the intensive care team about your wishes or your dad's wishes. Okay. So that would be very important to distinguish here. You know, it also sounds to me like your dad has gone through hell with being abused in a long-term facility. And again, I'm so not surprised. I know you are writing this from the US. I'm so not surprised to hear that your dad has been abused in a long-term acute care facility. That is just heartbreaking, but it's also what unfortunately happens across the board in those LTACs. So I hope that answers your question in terms of where you stand with NFR and DNR, because the unfortunate reality is if you tell them he's a full code, that also means they would need to intubate him and put him on a ventilator to keep him alive if it came to the point where his heart stopped. So you can't have it both worlds in a situation like that, right? So I hope that makes sense, Nate. All right. Now, if you have any questions that you want to ask, type them into the chat pad, or join me live on the StreamYard link here by clicking on the StreamYard link, and you can talk to me directly. I don't bite, and I welcome you to ask as many questions as possible while I'm here. And if there are no questions and you just want to listen in, let me move on to the next question. I have so many questions sitting here. Yes, I want to talk about this one where Loretta says, regret and guilt. So why does Loretta say regret and guilt? So I don't know in what context this is. However, you know, when people opt in for our email newsletter at intensivecarehotline.com, and you can do that if you go to intensivecarehotline.com, we offer a free instant impact report, that will help you to manage intensive care teams, get the outcomes that you want, etc. We ask them, what is your biggest frustration right now when they opt in with their email address? And Loretta says regret and guilt. Now, like I mentioned earlier with Michelle, never ever make decisions today that you regret in 12 months' time. Never ever. Because imagine you agree to a withdrawal of treatment today, your loved one passes away, and then you realize, if I had only given this a chance. Wayne Gretzky famously said, you miss 100% of the shots you don't take. Very true. If you don't try something, you have already lost. You have already lost if you don't try something. Okay? So really, really important that you try. And there's plenty of time to talk about end of life in intensive care. Plenty of time. Where's the rush? Where's the urgency? Right? So don't be guilt-ridden. I also made a YouTube live a while ago. What if the intensive care team is going to guilt trip you? Because it could be in another context here too, where the intensive care team is trying to guilt trip you to wanting to continue treatment for your loved one. Well, you shouldn't be guilt tripped by anyone, because at the end of the day, once someone has died, they have died, So you have to very carefully weigh up whether letting your loved one go is the right thing or not. Okay, I thought that was important to mention. Let's move on to the next question. If you have any questions, please type them into the chat pad, or join me live on the StreamYard link here, and I will talk to you directly and answer your questions here directly. We will be going for roughly another half an hour. So you still have time to talk to me here directly. Now, next question comes from Desiree. Desiree says, hi, Patrick. I'm reaching out from Biloxi, Mississippi. My mother has a tracheostomy, but is not on a ventilator. I'm having difficulties finding an outpatient dialysis treatment that will accept her. So I've now began looking into home dialysis, but I'm still getting hit with roadblocks. It's currently up in the air as to whether a local facility will train her so that she can receive treatment at home. Is this something intensive care at home can help with? Yes, absolutely. So the outpatient for dialysis might be an issue here, because they simply are scared to take on your mother because of the unstable airway. So here is what I would strongly recommend. We might be able to do dialysis at home, we might, but also once your mother has 24-hour nursing care at home with intensive care at home, that is when our nurses can also take her to the dialysis facility, and manage the airway, which is probably where some of the concerns are coming from here. Right? So it's actually an easy fix one way or another. We can help you, with our network. We should also be able to help you with getting her to a dialysis center. Because they simply, even the dialysis centers, they don't know what they don't know, that there's help at hand by having the nurse there 24 hours a day, and taking her to the dialysis center as an outpatient will help them manage the risk. So I hope that helps and makes sense to you. Now, let's move on to the next question. In the meantime, if you have any questions, type them into the chat pad, or type them into the chat pad or join me live on the StreamYard link here. I posted the StreamYard link into the chat pad here. Now, let's move along to the next question. And also, if you like my content here, subscribe to my YouTube channel, click the like button, click the notification bell, share the video with your friends and families, and comment below what you want to see next, what questions and insights you have. And if you want to, you can leave a small donation at the YouTube Super Chat button and support our work. Every little helps, so we can make as much free content for families in intensive care. Okay, so now, Peter. Hi, Patrick. Top of the day to you, and thanks for all your valuable advice for ICU patients and families. You're most welcome, Peter. It's a great pleasure. And thank you for your kind words. Can you please drop the link to your email for correspondence? For sure. I will. You can correspond with me here. I am just typing it into the chat pad here now. It is support@intensivecarehotline.com. If you want to, if you have questions now, you can type them into the chat pad, or you can join me live on the StreamYard link that I just posted there. If there are no other questions, I will move on to the next question from Christine. Christine says, hi, Patrick. My brother had an aortic valve replacement on April the 11th, 2024. The surgery was successfully. Woke up, and on the next day they had him out of bed and walking in the unit. And then it was like a switch was turned. He became combative, flaring his arms, pulling and pushing things. They sedated him. Then they discovered that he had that he tore the stitches on the aorta valve. Back to surgery. The repair was successful. However, he never woke up. He's ventilated now, and they had to put a tracheostomy in. They had to put a tracheostomy in, put him on dialysis. He's still not awake. Wow, that sounds like a full-on situation. Look, an aortic valve replacement can be very straightforward. And if it's straightforward, patients are often out of ICU within 24, 48 hours, right? In this situation, obviously, there were complications, and he ended up, sounds like he was tearing the stitches, and he ended up going back to surgery. Now, that also means he probably had massive surgery twice within, by the looks of things, 48 hours, right? You know, an aortic valve replacement can take hours, 3 hours, 4 hours, 5 hours. It's a long time where patients are under anesthetics. They're on a bypass machine, often, not all the time, but they're often on a bypass machine, right, where the bypass machine takes over the function of the heart while the aorta is being replaced. Now, unfortunately, I have seen patients in ICU after surgery or waking up after a trauma becoming combative or flaring his arms, pulling and pushing. I've seen that, unfortunately. Now, if you can't get that under control, if people stay combative and so forth, there's not much you can do, unfortunately, besides, trying to talk patients through the experience. But if they're confused or agitated, there's really not much you can do. And you need to sedate him and start ventilating him. That is by no means an ideal scenario, and it can set patients back, which is what's happened here, right? Also, I have to say this, while I said the valve replacement was on April the 11th, me recording this video today is the 14th of July. I have so many emails sitting in my inbox. So the email was sent on the 2nd of May. Right. So, but again, I have so many emails sitting in my inbox that I can't get to all of them. So, what should you do? Well, my advice here is you need to give it some time, right? You need to give it some time and let him wake up from the induced coma, right? And you need to make sure that all sedatives and opiates are discontinued, right? Because when someone has a tracheostomy, one of the main purposes of a tracheostomy is to not need any sedation or opiates at all. A tracheostomy is so much easier to be tolerated compared to a breathing tube. So keep that in mind, please. Now, also, if he's not waking up and he has been off sedation and opiates, he might need a neurology consult, and he might need a CT scan or an MRI scan of the brain or an EEG of the brain. That is what should be happening next. Okay, so 2 major surgeries within a couple of days is not a good thing. Not a good thing. Okay, now I hope that answers your question there, Desiree. In the meantime, if you have any questions, please type them into the chat pad or join me live on the StreamYard link here, and you can talk to me directly. In the meantime, I will keep reading out questions that have come in. Some of them have come in this week. Some of them are from way back when still, because that's how many questions I'm getting. Okay, so got a YouTube comment here from Modema. Hi, Patrick. I'm curious as to your experience between the different COVID-19 variants and ECMO-related outcomes, morbidity, etc. My impression is that the earlier variants had better success with ECMO treatment as opposed to the Delta variant at the time. I lost my perfectly healthy 47-year-old active duty physician husband to early Delta in July 21. 1 month ICU and over 3 weeks on ECMO. After 21 days on the ventilator, they performed the tracheostomy surgery and things rapidly went downhill from there. Secondary infection in the lungs of all places, and then brain bleeds in both hemispheres. Even though the outcome was terrible and I have significant post-traumatic stress from being at his bedside watching everything go down like it did, I'm truly grateful to have had those extra weeks with him. So it's a very difficult conundrum all in all, but I thank you for your video and appreciate your perspective and honesty on this subject. Look, I can tell you what I have experienced during COVID in terms of what families in intensive care told us, what colleagues told us. I did no longer work in ICU during COVID, but I've got a wide network of ex-colleagues and also nurses that we employ that still work in ICU. I cannot comment on the different COVID variants and ECMO-related outcomes. I think people have died with COVID early on. They died in the middle of the pandemic, and they kept dying towards the end of the pandemic. However, as the virus sort of was mutating as the pandemic went along, it also showed up in weaker and weaker forms. So it is probably fair to say that in the early stages, especially during the Delta variant, that the mortality rates might have been higher then than in the latter stages. Now, also from what I read is that many patients went into ICU with COVID. They might have ended up on ECMO, might have had COVID pneumonia, and then it developed into a bacterial pneumonia or into a fungal pneumonia, and they might have more than one, they might have had a virus, a fungal infection, and a bacterial infection. That also became evident from what I understand. So, I also understand some patients pulled through fine, some others didn't, of course. So it is difficult for me to say, whether it was the Delta variant that killed your husband or whether it was something else. It's difficult for me to say without looking at medical records. This is why. And I also know, having spoken to you here on YouTube Live, Modema, I also know that, you only found out about my service after your husband passed away. And this is what I'm saying over and over again. You can't wait to get a second opinion. You can't wait to get expertise, right? If you do that, you are fighting a losing battle. I don't know what happened to your husband, but if we looked at medical records, maybe we could have changed the course of his trajectory. But I think it's also important to note for anyone where you say, even though the outcome was terrible and my husband passed away and I have significant post-traumatic stress from being at his bedside, watching everything go down like it did, I am truly grateful to have had those extra weeks with him, which brings me back to, what should families do in life-threatening situations? Well, you should try and pull all the strings and, give your loved one as much time as possible, because if your loved one is meant to die, they are going to die. But then you might cherish the time you had with them, even if it's only a few days or a few weeks, but life is precious. And some intensive care teams don't want to, give you the time. Some intensive care teams want to rush or hasten death. And clearly you didn't want to do that, and that worked in your favor. Maybe your post-traumatic stress would be even worse if you didn't have the time, with your husband in ICU. Okay, so let's move on to the next question. And if there are any other questions, please type them into the chat pad, or join me live on the StreamYard link. Okay, just give me 1 second. Okay, next question from Amanda, who says, "Hi Patrick, my husband has pulmonary fibrosis. He got COVID almost 4 weeks ago. We were told yesterday that he had only a few days left to live. Today, his pulmonologist came in and told us about ECMO. A few hours later, he went to surgery to get put on the ECMO. His lungs were failing. We feel like he got a second chance." Well, that is actually a really good question, Amanda. Let's take COVID aside for a moment. Many patients with pulmonary fibrosis, not all, but some patients with pulmonary fibrosis end up on a heart transplant list, on a lung transplant list. Pulmonary fibrosis relates to the lungs. Okay, so I have seen many lung transplants for patients with pulmonary fibrosis. Now, depending on how quickly they deteriorate with pulmonary fibrosis, they may sometimes get put on ECMO whilst waiting for a lung transplant, right? Pulmonary fibrosis means basically the scarring of lung tissue. And if lung tissue is scarred, right, no gas exchange can take place in the lungs, i.e., the lungs will be failing, right, leading to heart failure and all the rest of it. So by putting your husband on ECMO with pulmonary fibrosis, I'm not sure whether pulmonary fibrosis will be healed by that. It probably won't, because pulmonary fibrosis is mainly irreversible. It does require a lung transplant. But what ECMO can do is it might buy your husband time to get on a lung transplant list. That's what he will do, or it might do. And you're right, we feel like he got a second chance. I agree with you. I very much agree with you that this is what's happened here. And you should appreciate that he's now on ECMO and hopefully can go on a lung transplant list, right? So I hope that makes sense and helps you to understand what's happening there. Now, let's move on to the next question. If you have any questions in the meantime, type them into the chat pad or join me live on the StreamYard link here, or if you're watching this on replay, leave your comment below, or and then I can answer your question, you know, at a later stage in another video. Bear in mind, I do have so many emails sitting in my email inbox. You know, it might take a while for me to read them out. If you want your email written out, if you want your email answered quickly, leave a small donation on the super chat, the YouTube super chat, and then I will get to it as quickly as possible. Now, next question. Comes from Sarah Harris, who says, "Hi Patrick, I'm trying to find an advocate for alternative treatment for my elderly mum who's in ICU on a ventilator." Well, Sarah, you couldn't have come to a better place than here to help your mum with advocacy, right? That is what we do here at intensivecarehotline.com. You know, have a look at our testimonial section. We have saved many lives with our consulting and advocacy. I encourage you to reach out here at intensivecarehotline.com to help you with consulting and advocacy. Then let's get on with the next question. Where John says, "Hi Patrick, the doctors want to remove the ventilator of my mum. They say she may only survive a few hours." Okay, question for you, John. If they remove the ventilator of your mum and she dies, are you okay with that? Have you given consent to that? Are you the medical power of attorney for your mum? Right? So have you negotiated with the intensive care team? Have you told them in no uncertain terms no? You know, do you perceive that as legal, what they want to do? How long has your mum been in ICU for? Have you had a second opinion? Right? How much ventilation support is she on? Why did she go into ICU? What medications is she on? Does she have an advanced care plan? Would she want that? Right? By taking your mum off the ventilator without your or your mum's consent, could that be perceived as murder? I know it's a strong word I'm using here, but what is it? You know, you urgently need a second opinion, and you urgently need advocacy here before it's too late. We have saved many lives in situations like that by, you know, educating our clients on their rights, and by also talking to doctors and nurses directly and holding them accountable and saying that this is not acceptable and that this violates laws. Right? End-of-life care in ICU does not happen in a vacuum. It happens around laws, guidelines, policies, and procedures. Right? Again, I can't stress this enough, that end-of-life care in a hospital or in ICU does not happen in a vacuum. It happens around guidelines, rules, guidelines, policies, laws, procedures. Right? I can't stress this often enough. Everything in a hospital happens with a policy. Mopping the floor, cleaning the windows has a policy. So end-of-life care, withdrawing treatment, withdrawing the ventilator, definitely comes with a policy. and is attached to a law. You can't just kill people without getting consent. Think about that. Think about that for a moment. You can't just kill people without getting people's consent. But even if you have consent, right, there needs to be some checks and balances. Think about that. I can't believe how naive some families in intensive care are, that they think intensive care teams can just do whatever they want. They can't. They can't just do whatever they want. You know, once again, make decisions today that you don't regret in 12 months' time. Very, very important. Get the hospital policy for end-of-life care. Look at your local state laws about end-of-life care, whether a hospital can just remove a ventilator without anyone's consent. That is madness. That is absolute madness. Right? Don't lose common sense in situations like that. It's very important. Right? A lot of families in intensive care don't use common sense. Always use common sense. They can't just kill someone without your consent. Very simple. Question here from Scott, who says, "Hi Patrick, how late is too late to view my mother's hospital notes? She passed away in 2021. It's never too late, Scott. It's never too late to find answers for you. Never. So if you want answers why your mom passed away and whether there has been some medical negligence, let's start the conversation. You know, let's start the conversation around that. It's never too late to find answers. Right? Never. Very simple. You know, and this brings me back to when I say make decisions today that you don't regret in 12 months' time, which is what might have happened here. Look, I am speculating, you know, I don't know the ins and outs, but that is what often happens. Families get second thoughts when it's too late, and then they want, you know, all the research done, but then it's too late. You don't want that. You don't want it to be too late. Next question from Rebecca, who says, "Hi Patrick, I am very concerned about my brother in ICU with spinal cord injury to level C2 and the hospital wanting to send him to an LTAC. I would be concerned too, Rebecca, very concerned as a matter of fact, right? I would think that if he has a complete C2 spinal injury, right, which means he's a quadriplegic and he won't be able to move anything besides his head, right? If that, you need to have a long-term strategy, and LTAC is definitely not a long-term strategy. I would think that going home with intensive care at home would be the much better option here. Much better option, right? Than letting him go to LTAC. We have a number of C2 clients at home with intensive care at home. That's what I would be looking for if I was you. And definitely not let him go to LTAC. You can stop the hospital wanting to send him to LTAC simply by you objecting it. You know, no one can force you, and that's assuming you are the power of attorney. You know, no one can force you to go to LTAC at all, ever. Okay, I want to close this off today in a minute. Once again, If you like my videos, subscribe to my YouTube channel for regular updates for families in intensive care. Click the like button, click the notification bell, comment below what you want to see next, what questions and insights you have. I do a weekly YouTube live here, and you will get notification if you're a subscriber to my YouTube channel or a subscriber to our email newsletter at intensivecarehotline.com. We also have a membership for families of critically ill patients in intensive care, and you can become a member if you go to intensivecarehotline.com, if you click on the membership link, or if you're going to intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related. Also, in the membership, you have exclusive access to 21 ebooks, 21 videos that I've personally written and recorded, and that will help you to make informed decisions, get peace of mind, control power and influence, making sure your loved one gets best care and treatment. I also do one-on-one consulting and advocacy over the phone, Skype, Zoom, WhatsApp for my clients, and I will handhold you through this once-in-a-lifetime situation that you simply can't afford to get wrong, right? You can't afford getting wrong when you have a loved one critically ill in intensive care. You know, you can't wait until it's too late. Furthermore, I also talk to doctors and nurses directly, and I ask them all the questions that you haven't even considered asking. I also represent you in family meetings with intensive care teams. We also do medical record reviews in real time so that you can get a second opinion in real time. We also offer medical record reviews after intensive care so that you can get closure, or if you have unanswered questions, or if you're suspecting medical negligence. And all of that you get at intensivecarehotline.com. Call us on one of the numbers on the top of our website, or send an email to support@intensivecarehotline.com. Once again, with intensive care at home, we are currently operating all around Australia in all major capital cities and regional and rural areas. We are an NDIS approved service provider, DVA approved service provider, TAC and WorkSafe in Victoria, NIISQ in Queensland, and iCare in New South Wales. Our clients have also received funding through public hospitals, private health funds, as well as departments of health. So there's a number of funding avenues available for you and your family. And we're also providing level 2 and level 3 NDIS support coordination. And we're also providing specialist nursing assessments. Now, want to thank you again for watching. And I will talk to you again next week and during the week with quick tip videos and intensive care at home videos. Thank you so much for watching, and thank you for your support. This is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com, and I will talk to you in a few days. Take care for now.